On today's show, we have transformation executive Lisa White taking a pulse on value-based care and its state of alignment in our current health system, where it's going right, what it's getting wrong, and what are the changes that she sees as most needed for future success. It's all right here, right now, on this episode of Red Hot Healthcare. Let's go.
This is Red Hot Healthcare. Interviews with today's leaders and all the news that matters. Here's your host, Steve Ambrose.
Imagine the power of engaging, insightful content that resonates with your target market and inspires them to take action. Your organization is to be noticed, listened to, and trusted. Whether you're reaching out to patients or plan members, internal communication to your most valued employees, or you're connecting with future clients about your platform or point solution. My name is Steve Ambrose, and I help organizations unlock their potential by bringing the power of thought leadership content and brand messaging to those they most want to reach and engage. It happens across written, video, and company audio content involving your leaders, patients, clinical or product teams, as well as relevant stakeholders. And you can learn more by visiting redhothealthcare.com or connecting with me on LinkedIn. I'm here to help. And now, back to the show. I'm your host, Steve Ambrose, and today we have value-based care expert and executive Lisa White. Lisa currently serves as a transformation executive for a healthcare advanced analytics company that consults with payers and providers to create both strategic and tactical guidance to realize return on investment. Now, previously to this, Lisa was Senior Director of Value-Based Innovation and Strategic Partnerships at Horizon Blue Cross Blue Shield of New Jersey. Lisa, I am so happy to have you on the show today and aboard with us. Thanks so much for joining us.
Thank you, Steve. I am so excited to continue our conversation.
Yes, and let's just jump right on in. This is going to be a great conversation. And can you go ahead and please, at a very high level, just take us all through the birth and the current status of value-based care when we look at it through the lens of value-based models and perhaps past results?
Yeah, absolutely. And this story is not known broadly, but value-based care actually has a very long and storied history. If you can believe it, it actually technically began in the 1930s. So when the HMO was built, which we know languished, very low adoption for a long time, until 1973. So President Nixon signed the HMO Act in 1973, requiring employers to offer an HMO option. So that started the HMO thing. Then in the 60s, the American Academy of Pediatrics introduced the patient-centered medical home model, which was for chronically ill children, the way they designed it. There are other examples, but those core principles evolved over time and then surprisingly gained specific momentum and steam in the early 2000s, which some people credit this to. There was a book that was published in 2006 called Redefining Healthcare that covered a lot of this. So then you add HHS and CMS and poof, today's version of VBC. So results have actually been really mixed at best, but that's why we need to continue to evolve these programs. And we have to do it deliberately instead of these big nebulous, let's save money kind of goals. So if you wonder why the provider community often collectively rolls their eyes when you say a new and improved value program, it's because they know this story.
Yeah, it's so interesting that in my prior role at Innovator, I was all about doing this through their content side, and CMMI, Center for Medicare and Medicaid Innovation, was always top of mind in that organization. because they were very value-based care centered with their data. And I just read recently that it might have been a week or so ago that CMS launched yet another new pilot program to test out another value-based care primary, some sort of model in 8 different states. So I'm assuming that you're aware of this as well. And I guess maybe just as a backdrop of this, I think there's been something like over 50 different value-based care models from CMMI, and many of them have not done nearly as well as expected, right?
That's right. And complicating matters, right? So here's the interesting thing. Everything that's built through CMMI is government programs focused. Well, that's a slice of what's happening in the marketplace. You still have this massive commercial insurance pool of patients' members that need to be taken care of, and they need to be taken care of effectively. And so what tends to happen is stuff comes down from CMMI and everybody goes, oh, that's cool. Hey, we need to make a version for our commercial population or something that we could overlay to our commercial population. So then a payer will design a new internal program to either mimic or mirror parts or most of whatever this new thing is from CMMI. So while CMMI or CMS may have come out with, 50 something, then you add all of the other things that are designed by payers, managed service organizations, enablement companies, and there are hundreds out there.
The preface for our conversation today is around a post that I read you put on LinkedIn several weeks back about the misalignment around value-based care and a lot of the ways that the real-world operations and incentives work for physicians today. You put out a terrific post. It was very well liked and very well shared. And so going into this this interview here, first question here would be on how do you see the design of value-based care today maybe missing the boat and becoming misaligned or being misaligned with what's happening in the real world with everyday physician operations and perhaps incentives for physicians?
Yeah, if I could sum it up, I often say we talk all the time, all day, every day about we need to align incentives, but we don't stop first and align stakeholders. So payers rarely, if ever, have any insight into the internal compensation structure of their provider partner organizations. So you're basically creating an incentive program based on data, but you can't create a program that easily dovetails into how each organization is paying its clinicians. So right there, you're splitting their attention, right? The clinicians have their workflow going. We know that with the right framework, value-based care has a potential to make huge impacts. So in the last program I led, we had about a 6% difference in medical spend trend between those in the VBC program and those that weren't. But another factor to this is the lack of interoperability, which is also one of those words that everybody cringes when you say it, but it's true. We're not connecting to where and how the clinician actually works, which by and large is within the EHR. So, and sidebar here, any company who says they have a point of care solution but doesn't integrate with the EHR, it's not a point of care solution. So we've tried to build these programs in a silo without coming together and saying, okay, here's what we want to accomplish. We need to accomplish it together. Here's what I'm looking for. What are you looking for? And then let's figure out how we build this to incentivize the right activities that benefit the patient.
Now, why is that? Why would payers and other stakeholders not be thinking ahead to kind of connect the pieces as it seems so obvious they should?
It feels, when you're doing it, it feels like you are. You come up with these quality metrics, efficiency metrics, you come up with financial targets. There's lots of actuarial and Medicon work that goes into it. And it feels like you're creating something that is going to push toward meaningful change. The challenge is neither party trusts the other. And what I've found to be universally true, and I've been partnering managing provider relationships since the 1990s. What I have found to be universally true is that both the payer and provider sides come to the table with an underlying mistrust of each other. And that right there sets the tone for, we're not going to build this together. We're going to build something, provider. You're going to come back and argue with us about what we've built. We're going to make some concessions and change a couple of things. And then you're going to come back with reasons why you need an exception to this and this and this. This is why, I'm not kidding you, Steve, these value contracts take 18 months to negotiate. So when I've just closed out a contract cycle on some value programs, I am already negotiating next year's and the following 3 years. Because that's the way we've set up the work. And it all, to me, is rooted in distrust.
Yeah. And, when we talk about trust, and 18 months to put something like that together, is there reason to distrust? Is there just a long-standing track record between providers and payers where it's like, look, we have to do this, there's pressure to do it, let's just get it done? Is there any way to shorten these contractual periods up and maybe sort of catalyze greater trust from the onset?
Yep. To me, what I've seen to be consistently true is providers are suspicious because they're not looking at the same data that the payer is looking at. They're looking at, in many cases, their own data. So they know generally, what the patient spend is, or they know, where their outliers are for utilization. As far as big buckets, they might look at a clinical cohort and say, oh man, our diabetes patients are really costing us a lot of money. Maybe we need to focus more on a more robust diabetes program for our patients. But neither side is looking at the same set of information. So you have all this, and by the way, this actuarial work that's done in the payer also is what feeds into premiums. So there's actuarial work forecasting. That's how premiums are determined. And those actuarial activities are fed into, okay, what is the financial target we're setting for this provider based on what we know about their risk pool and about their what they get paid and how they run care, right? How they manage care. So what tends to happen is, I might go to a health system partner and say, well, for your PCPs, we've set your PMPM target next year at $539. Mm-hmm. And your risk score, your aggregate risk score is X. They don't think that's appropriate because they're looking at something that tells them something slightly different. One of the things we've got to get to is we've got to get to a place where we are transparently sharing and discussing the same data. You asked what'll make a difference. It's transparency. And even when one side thinks they're being transparent with another, it's not like I'm opening up my payer data and letting my provider partners look directly at it or vice versa. So there's got to be some centralized opportunity, and actually a product recently launched that I'm watching that hopefully will help with this. That's really a two-sided modeling tool where the payer and provider can do their own inputs and then be looking at the outputs. They can model, all right, if my catastrophic cap is going to be $150,000 per patient, how does that impact me overall cost-wise versus $200,000 per patient? So they would be working in a scenario where they're looking at the same modeling, they're looking at the same information, feeding from the same set of claims data.
The latest stats here around value-based care seems to be feeding directly into, almost exclusively, from what I can see, into primary care. you just don't see a lot of value-based care attaching into secondary care. And by that, I'm talking about, of course, specialist services, surgeries, therapies, that sort of thing. Primary care only accounts for about 8% on average of all healthcare spending, Lisa. So when we look at the impact that value-based care needs to make around all healthcare costs, not just quality, but costs, it really appears that until it starts hitting into secondary care as well, it may not make the push that everybody expects it does. Now, am I wrong on that? And how do you see it eventually getting into and being adopted on a secondary care level by providers?
Yeah, you're not wrong. But there is a reason why these VBC programs, by and large, are primary care centric. The original idea, going all the way back to the PCMH in the 60s, the HMO in the 30s, the original idea was we need to go back to what I lovingly call an old country doctor model. So you remember Little House on the Prairie? Some people listening might actually be old enough to remember that. Doc Baker saw everybody for everything. He knew everything about your health history. He knew when you needed something special. He knew when to send you up to Mankato for whatever your surgical needs were, right? And so the idea was we need PCPs because that's generally where a patient has develops their strongest relationship. We need PCPs to act as the hub in the wheel. And we like air traffic control, right? So we want to enable PCPs to understand what's happening with their patients so they have the opportunity to coordinate that care better. What has happened, so it's intended to incentivize active referral patterns, if nothing else, right? So when you talk about specialists, hospitals, ambulatory surgery centers and all that, it's intended to incentivize active referral patterns to high-performing specialty providers and facilities. The problem is, in most instances, we can't give PCPs the right data to know who those specialists and facilities are. So ideally, we'd create a scenario where specialists would go maybe on subcap or global cap within the PCP program and be part of sort of, for lack of a better descriptor, narrow network, but a robust network with lots of network coverage that would say these providers are the best of the best. If you want an orthopod, send them to one of these three. If you need a cardiologist, send them to one of these three. We would have this information to know who the top performers are. Right now, PCPs just need to be able to see where their patients are going when they're not coming to them. And as an industry, we struggle to do that. So that's one big piece of it. We also need to refine a system where PCPs are actively referring to those high-performing specialty and facility partners. By high-performing, we mean best outcomes, least waste, okay? And so we need them actively referring to those. So the difference between an active and a passive referral being, passive referral would be, for instance, you need to see an orthopod. But changing it to, you need to see an orthopod, and here's a list of 3 top quality orthos we recommend. Because if the provider is just saying, you need to see an orthopod, you know what I'm doing? I'm going home and I'm calling Aunt Betty, who had a knee replacement last year.
Right.
And I go, Aunt Betty, how was your orthopedic surgeon? Were you happy with the treatment you had? And so they're self-directing based on information that's not relevant.
Wow. No, it almost sounds like a little bit of consumerism in there as well from the patient's end.
Absolutely. Yes. The healthcare system, I will fight people on this, is consumer driven. And this is why we have things like Leapfrog. Leapfrog would not even exist and Hospital Compare if it weren't for the fact that patients, consumers, we're all patients, right, started asking questions. How do I know who the best hospital is? How do I know where I should be going, right? So things like that, that's where they came from.
Let's stay on that. Let's stay on that thread of consumerism for just a bit. I want to address with you, Lisa, what's been largely a taboo topic on the lips of payers and providers, and certainly their leadership, and that's a growing what I wholeheartedly believe is a silent yet fast-growing epidemic of unaffordability in healthcare. I mean, it's not just affecting the lower income population, it's affecting all populations, particularly with higher out-of-pocket payments. And it's getting to the point where it's impacting medication adherence, but also, care avoidance. People are avoiding surgeries. They're avoiding going to doctors. They're avoiding therapy. They're avoiding lab tests. They're avoiding even their regular checkups. And a lot of this is just because the costs are prohibitive, and at some point, it's even at a basic level interfering with their rent or their food payments. And I want to address with you when we talk about value-based care helping healthcare costs, because healthcare costs seem to always be attached to value-based care. But when we talk about individuals and affordability and needing to make, let's say, prices in the future lower and make this less of a friction point, how do you see value-based care doing that? And can value-based care have the power to do that?
Yeah, this is a huge pain point for me personally, because I'm hyper-focused on how a program like this ultimately benefits the patient. Because we can build, right, like I said, we're all patients. We can build the best insurance policy benefit program. We can build the best network. But access does not equal affordability, as you point out, right? So we've tended to be so focused on the actual utilization dollars, which is a fair point, right? But we have not had conversations, at least I have not been privy to any conversations, where we have been very transparent with, for instance, our self-insured customers to say, listen, I love that you want to give your employees this very rich benefit set, but I can't control your costs the way you want me to. I can't intervene. The PCP can't intervene if your employees have the platinum card and can go anywhere and everywhere as many times as they want. And I bring that to the fore because this all plays into those premiums, those co-pays, how all those things are decided and paid for. So I want to paint you a very specific picture. So if you have, and this is actually from some real experience, if you have a state employees plan, so you're insuring all of the employees that work for whatever state this is, and these are benefit plans that are notoriously very rich in benefits. The theory being, of course, that they want to be as competitive as possible in the marketplace. They don't want to lose government employees to private industry. The challenge with that is we've not had frank and transparent discussions with self-insured employers like that to say, that's great, but I need you to see the end result of that. And the end result of that can be massive overutilization, which is going to hit your claims cost. It can be complete lack of utilization because the way you've built it, they're not incentivized to go to seek quality care for whatever reason. Maybe it's their $50 copay, maybe it's their, $2,000 deductible, whatever it is. But so in New Jersey specifically, there was actually litigation about this years ago, and it resulted in the courts saying, no health plan, you cannot force a provider to collect a copay. And at the same time, part of this litigation determined that the health plans cannot drastically reduce the amount that they pay for out of network, because a lot of people don't understand, even if you're not in network with the health plan, you can still bill them and get paid the out of network rate, which is usually 60% or something of whatever the going rate is. So what ended up happening is there are a lot of, and this is pretty much industry wide. There are a lot of physical therapists, as example, physical therapy, acupuncture, chiropractic. These are three really good examples of industries where they are perfectly happy to stay out of network and take that out of network payment just to not have to deal with the health plan, right? And claims and do all that crap. They're happy with it. And at the same time, the plan has been told, okay, well, you can't force them to collect a copay. So there are actually provider organizations that go out and advertise this way and say, yes, we will take your XYZ health plan. We take all XYZ health plan participants for $0. And they do volume.
But that's a fair point, Lisa. But I would say that when you look at physical therapy and chiropractic as a whole of all medical spend, I mean, they're very, very small. I think chiropractic is 0.1% or some such number of all medical dollars. So I'm talking also about things like the American Medical Association's Relative Value Unit Committee that sets the prices. Right. Let's be honest. I mean, Medicare, quote unquote, sets the prices, but 95% of what they adopt is from the AMA's Relative Value Unit Committee. So, I mean, at some point with value-based care, it just seems to me that everybody's going to have to give a little bit if we're going to have to not only enhance quality and outcomes, but also at some level look at costs on a personal level, on a patient level, rather than just a business level.
That's right. And that's exactly what the picture that I'm painting. We don't have those discussions with the employers to say, okay, this will be the potential outcome cost-wise of how you've designed this plan. We don't have those transparent conversations with providers saying, look, we need you to do XYZ. There are a lot of really great people working in value-based care. A lot of really great, smart, dedicated people. We still haven't found that sweet spot of transparency where we are focused on the patient, where we are saying, yeah, I understand you want to get paid X% of CMS rate for your E&M codes, but let me explain what this translates to for your patient when their co-insurance is 20%. So that's where value-based care starts having conversations like repeat advanced imaging. How do we know if repeat advanced imaging is actually worthwhile or if it is wasteful and we could have gotten everything in one shot? And the point that I continually make when I'm having these conversations with providers is if you're sending your patient 3 times for advanced imaging that we could have done it all in one shot, guess what? They're paying 3 bills that's coming out of their pocket. They are also paying 3 copays or 3 co-insurance bills for those tests. So there's a natural progression of how this rolls down to the patient that we're trying to focus on in value-based care. Because if you pull it all up to the macro level about value-based care in the advanced imaging scenario, we're talking to them about, hey, your radiology costs, are suddenly off the charts. Do you know what's going on? Instead of saying, do you have any insight into how efficient the prescribing of your advanced imaging is being, or the quality of your advanced imaging outputs are?
That's such an interesting point. As you're explaining that, Lisa, one of the things I'm remembering is I did an interview a few years back with Dr. Vivian Lee at Verily Life Sciences. She's the president there, and she wrote a book called The Long Fix, Solving America's Healthcare Crisis. In that conversation, one of the points she made that I had no idea about is in most every country, when they price out drugs, specialty drugs in particular, that they will look at the clinical effectiveness of the medication and tie that directly into the pricing. But in the United States, they don't do that. In fact, it has been vehemently opposed to ever have that adopted in. So right from the get-go, and I don't want to make this all about pricing our conversation, but right from the get-go, systemically, it seems like we're up against it within the U.S. healthcare system on a number of levels around this.
Yes, absolutely. And you know who's really great at that is France. Among others, but France. Big fan of France. But yeah, so you look at what just happened with Medicare, right? Medicare being allowed to negotiate prices for drugs. Any rationale says, who in the world thought it was a good idea for Medicare, one of the biggest costs we have in this country, to not be able to negotiate in a free market the way anyone else does? And so we've essentially hogtied, as my granddad would say, every government program by doing this. And so now we've got this whole, as you know, we've got this whole brouhaha going on about, oh, we can't let Medicare negotiate drug prices. Yes, you actually can, because that's how this market works in favor of the patient. And look, if you don't have patients taking your drugs, guess what? You're out of business. And if patients can't afford your drugs, you're out of business. And if the payer won't cover a drug because you haven't proven its efficacy or its valued use, then who suffers? The patient suffers. So we've ended up in this whole, it's like this whole maelstrom of, pharmacy. No. Now we need to focus on imaging. No. Now we need to focus on that. And it takes a lot of political will. And I don't mean like national politics, organizational political will to say, this is the right thing to do. It's the right thing to do for patients. It's the right thing to do for members. This is what we need to do. And we need to get people to collaborate with us on this because it is the right thing to do. There are very few out there that'll do that.
And just to close the conversation, not to get too political, but as I understood it, it was a part of the Affordable Care Act that the drug companies were not going to sign on to the Affordable Care Act during the Obama presidency unless that provision was made that Medicare could not negotiate. In other words, that was the lever that was going to keep them out of, and passing the Affordable Care Act without them would be an impossibility. So it to your point, I think, yes, it's very political. I want to move on to artificial intelligence. I think that's probably a topic you might have heard a little bit about in the last 2 months.
Possibly.
Yes, exactly. And if you didn't, it would tell you had.
That's right. ChatGPT would tell you what you missed.
Oh, ChatGPT. Yeah. Well, we have to address it with value-based care. And of course, this is one of the questions I was most interested in asking you and getting your thoughts on how you see artificial intelligence, and not necessarily just generative AI with ChatGPT, perhaps, machine learning and NLP. How do you see artificial intelligence as a whole, Lisa, improving this value-based care alignment with physicians?
I have actually seen some really robust and proven use cases for AI to assist. Things like diagnostics. So back to my point about the advanced imaging. If there is a robust AI application that it helps sharpen the diagnostics the first time, guess what? We avoid that second and third time. I've also seen some AI that's really good at taking claims and encounter data and turning it into risk predictions. Those risk and rising risk for patients, those predictions help clinicians intervene with patients before they get sick or sicker. So in that respect, we can be leveraging a very strong potential with AI to help with value programs by quarterbacking these things, like rising risk, for a PCP to know where to focus their efforts for the most impact. I don't believe that. I've had, actually, my nephew just asked me this week. He's like, "Oh my God, do you think my job's going to be taken by AI?" And he's this brilliant data analyst. He's really amazing with healthcare data. And he asked me that. I was like, listen, I have lived through the advent of personal computers, cell phones, the internet, all these things that everybody said, oh my God, the world's going to explode. Nobody's going to have a job. That's not what happened. And so I don't think AI is ever going to replace the human component of healthcare, but I think it has massive potential if we leverage it effectively to help providers gather the right and best information. One of the big challenges, as you know, that we have in the industry right now is PCP burnout, clinician burnout in general. But PCP burnout is at an all-time high. PCP suicides, how did we get to that, is at an all-time high. And this is why you'll hear those of us who've actually been in value programs for a long time, we talk about the quadruple aim. So there's the IHI's triple aim, which is cost, quality, and patient experience, which is sort of the three parts of the stool, legs of the stool, that are supposed to be holding up value-based care. There are those of us that refer to the quadruple aim because the fourth pillar of that is provider experience. And if we keep designing programs that inadvertently cause more strain, more workload, and inefficient workload for providers, we're just going to keep feeding into that. I've seen so many opportunities with AI, and there are a lot of really great people working on this. I stay really connected to a lot of them, where AI can be almost like an adjunct professor coming in and helping to smooth and create efficiency for reading radiology or, creating a diagnostic workflow, whatever it is. So I think it has massive potential. And that's how it would all feed into value-based care. Because if we are true to that triple or quadruple aim, one of the things we got to pay attention to is how we leverage technology to make the provider's job more efficient and better manageable.
Let's move into another surging topic, and particularly in its link to value-based care and alignment to value-based care, since we're chatting alignment, Lisa, and that is retail entrants in healthcare. So we certainly, unless we've been under a rock here, we know about CVS Health and Walmart and Walgreens and Dollar General's even getting on the map, and you've got Albertsons coming in, and just all sorts of different retail, trusted names in retail, Amazon, of course, coming into healthcare's primary and home healthcare segments. And, I'd like to know from your end, where do you see these players having a role or having an alignment in value-based care and care coordination? Because one of the criticisms is, hey, they're just picking into primary care. You got high out-of-pocket costs. You've got, a lot of access issues in rural parts of the country. Boy, they're just snagging the low-hanging fruit. They're not really interested in connecting into health systems and coordinating care and population health. They just want to snag what's there and what's ready for them. So all of that leading up to the point and leading up to the question that, where do you see retail entrants, their role in value-based care alignment, and in moving forward, how do you see this all playing out?
Yeah, so your criticisms are not misplaced. They are in fact true of some of these players. But back to my point earlier about consumerism in healthcare, one of the things that I think the industry is finally wising up to is we have to meet patients where they are. And if they're going to the pharmacy once a week because they're bored, if they're going to the pharmacy once a week to check their blood pressure, if they're, whatever the scenario is, I'm actually specifically excited about the potential to tie all of these access and encounter points together, which I think some retail-based companies are well poised to contribute to. So when I was a kid, I use this story a lot. When I was a kid, my dad was a long-term cardiac patient. I clearly remember going with him to the Rexall Drugs, where I would, of course, get a Coke float at the counter, and he would have a long conversation with the pharmacist. He developed a a trusted clinical relationship with his pharmacist. And he would talk to the pharmacist. He's like, yeah, I got to go talk to Dave today because they want me to go on this other medicine. I need to talk to him about it, see if it's a good idea. That pharmacist was quite literally part of my dad's care. And so I think if we harness the right things, then we are actually flowing information better. So I'm going to use Walgreens as an example. So Walgreens has health corners. So they're building health corners, which is somewhat a walk-in clinic, but they are very deliberately building it so that it does not pick off or try to take attribution away from primary care providers. So one of the things that they invested in was a nationally known EHR. So they're creating a scenario where they actually can push EHR information back out to the patient's PCP. So if you put it in this big context of they've got health corners, they're tied to pharmacies. So if the person, comes in, I read the story about Walmart and it's not untrue. I often refer to it as the grocery store. They come into the grocery store of care and they go, oh, I need something for this cold. But wait, here's this walk-in clinic. Maybe I could go to this walk-in clinic while I'm here anyway and find out if I need antibiotics versus just, over-the-counter cold medicine. That's a perfect example of meeting patients where they are. And in the Walgreens example, they're not only sharing back to the PCP, in places where Walgreens is co-locating with VillageMD, they actually, and by the way, they have a mandate, VillageMD has a mandate from Walgreens to do 40% of these co-locations in underserved areas. So if you think about the fact that they're now creating a one-stop shop in a place where the pharmacy already is and people are already coming to, this garners a lot of opportunity to get people in front of PCPs who can start coordinating their care. The thing is, healthcare is not easy to solve. If it was, we would have solved for all this stuff long ago. Perfect example, Haven. Haven was founded by some of the brightest minds in business, and it still wasn't successful because I don't think any of them bargained for, yeah, okay, there's way more interdependencies and way more complexities than we ever gave thought to or tried to solve for. I think overall, the overarching issue is that we don't have the right voices in the room. We have incredibly smart people doing really innovative things, but they don't always have all the right voices in the room.
Lisa, that is a great segue. I wanted to ask you also, when it comes to innovation, and there's certainly no shortage of business-to-business vendors, IT vendors, and organizations and technologies in healthcare, who do you see as being the big winners and perhaps maybe the losers when it comes to value-based care and its alignment with providers and payers?
Here is one of the well-known, but nobody wants to talk about it, issues, which is there is massive opportunity in provider data management. One of the things that people don't often think about is what's the underlying infrastructure that's feeding into this program. And provider data management is a perfect example. It is so broken, it is so ineffective, and that provider data management, for instance, drives where a patient is attributed, so which panel they land on. And if that's not right, the patients are not being linked to the right doc. They're out in the stratosphere. I mean, there's nothing coordinating what's happening. And by the way, this PDM system is the underlying system pretty much for everything that happens in a health plan. Everything from claims to, everything. So if it's not right, it's bad. That's a bad thing. If the provider data is wrong, it also fragments patient data. So for instance, if we're not getting the provider data correct and we're not matching like NPIs on a claim, we don't necessarily have a way to tell that provider where their patient has been when they're not coming to them. That's a huge one, huge. Another one is organizations who are EHR agnostic, so they can work with any EHR and can push clinical data effectively. Clinical data exchange is still a nightmare. And not for nothing, there are organizations still using fax machines. Don't get me started on that.
Right.
Don't get me started. But clinical data exchange is so mission critical for us to be able to see, us being payer and or provider, being able to see, is this patient really getting the right care? Perfect example of this is ED visits. So if you have a patient, let's say you have an elderly patient that falls and goes to the emergency department, and they're doing her intake, they're doing her H&P, and they ask her a bunch of questions about her health history. And during this conversation, she says she has asthma. So that gets coded because of that H&P in that ED encounter, and it gets attached to her. What the ED physician can't possibly know is that she doesn't have asthma. She just had a bad upper respiratory infection last year, and they gave her a nebulizer. So she's equating nebulizer, I must have asthma, right? Because her cousin is on a nebulizer because of her asthma. So now you end up with this thing attached to this patient that's not accurate. And the only way to pull that back is to make sure that the PCP is coordinating all of that. So that's my pontification about clinical data exchange.
Yeah. Who are some companies in that space, maybe one or two that come to mind that you would see as big winners?
I think Moxe Health actually does this really well.
Mm-hmm.
And they are agnostic. That's one that I've had a relationship with for several years. I think in the diagnostic space, for not just this is sort of a holistic answer to 4 of your other questions. Covera Health also does an amazing job of AI in radiology for best diagnostics, and ultimately then the EHR drop, because they're a certified patient safety organization. So they can actually drop this data right back to the provider, which is a much more efficient and effective way to achieve clinical data exchange.
And are there any I don't want to use the term, well, I'll use it. Are there any potential losers that you see as value-based care becomes more better aligned with provider and payer needs? Do you see vendors or IT organizations that have sort of gone past their time or past their model?
I think potential losers would kind of go in the bucket of those who push point solutions that might be technically really strong and really great. They might have a really great UI and, it's wonderful, but they're not informed by the expertise of individuals who have done the work. So clinicians, operations experts, because and I work with a lot of really incredibly smart product developers with the right motivations and the right background. But unless you've actually sat in that seat and done that job, you can't possibly know or understand the complexities and nuances of actually getting that job done. So what I see very often is, I used to have vendors calling me all the time and drop AI and ML. And I thought, oh my God, if I hear that one more time, I'm going to lose it. I want to know that you understand my problem and you have figured out a solution that could help me with my problem. And I think that's where any of these point solution vendors, and by the way, I'm a big fan of point solutions because I don't think there's such a thing as a jack of all trades when it comes to technology, especially advanced analytics. I think if you get an organization that's incredibly good at oncology, you hire them for oncology. If you get an organization that's incredibly good at kidney care, you hire them for kidney care. So there's no one size fits all. But the ones that struggle are the ones that are so focused on the razzle dazzle of what they're doing They haven't stopped to say, hey, operators, poke holes in this. Tell me why this won't work. Tell me the reasons why the provider will not use this, or why the internal to the organization won't use this. Because you can build the sexiest program on the planet, and if you don't get adoption, great, it's another doorstop.
Lisa, if you could snap your fingers and fix just 2 things wrong with value-based care design and alignment today, what would they be and why?
The first is that all value programs would be co-built by payers and providers for all of the reasons that I explained earlier. The second one is empowering providers with the right kind of information about where their patients are going when they aren't coming to them, that help them to understand the care that's being given, the care that's needed, and the care that they need to coordinate.
Lisa, I want to thank you for stopping by the show today. Really enjoyed the time and your insights, and it was an absolute privilege spending time with you in conversation today. Thanks for coming aboard.
Thank you so much for the invitation, and I look forward to working with you some more.
And for our listeners, don't forget to check the show notes for links and resources and contact information related to today's show. And stay tuned to Red Hot Healthcare for more shows covering the healthcare topics and challenges that you care about. For more information on this and other shows with great leaders and luminaries, please visit redhothealthcare.com.
You've been listening to Red Hot Healthcare with Steve Ambrose. Subscribe to us on most major podcast directories. For media or business inquiries, reach out to media@redhothealthcare.com. Thanks for listening. This is Denny Colonna. We're out of here.